my name is Dr. Stephanie Graff. I'm a breast medical oncologist at Brown University in Providence, Rhode Island in the US. I am at ESMO Congress 2025, and today I'm doing an Ask the Expert session on some of the new data that's emerging around CDK4/6 inhibitors here at ESMO Congress. Dr. Rodriguez from the US says, with new data emerging from NATALEE and monarchE trials, how are you interpreting the long-term outcomes for adjuvant CDK4/6 inhibitor use in early hormone receptor positive breast cancer? We saw here at ESMO 2025 that NATALEE gave us long-term outcome looking at their 5-year invasive disease-free survival and shows continued improvement in invasive disease-free survival with adjuvant ribociclib. With monarchE, we saw an update at 7 years showing an improvement in overall survival. The first time we're seeing CDK4/6 inhibitors improve overall survival in early stage breast cancer. Both of these are, critically important as we think about how to utilize these drugs in early stage breast cancer. And honestly, I think both of those trials give us just continued confidence in using those therapies. Obviously, NATALEE with ribociclib was not powered to show overall survival and is a lower risk population that's a little bit farther behind in terms of timeline development. So overall survival for that study is both not yet mature and not reached, but we're seeing that continued creep toward that endpoint as they show us the overall survival endpoint anyway. And with now monarchE showing overall survival with abemaciclib, despite large numbers of those patients going on to receive adjuvant CDK4/6 inhibitors, I think it really just promotes our ability to understand that using CDK4/6 inhibitors in early stage breast cancer is an effective therapy that's not having negative consequences on our long-term health of our patients. And that's really powerful information that helps give me confidence in using these therapies to help prevent more metastatic breast cancer recurrences, which is really what I'm hoping for in the clinic. Next question is from Dr. Duarte in Spain, who asks, how are you approaching the management of endocrine therapy side effects in premenopausal patients, especially when adherence becomes a challenge over long treatment durations? So in premenopausal patients, that's an excellent question. With a premenopausal patient, especially with high-risk disease, we're often considering ovarian function suppression plus an aromatase inhibitor plus a CDK4/6 inhibitor. So we've got a lot going on for that patient. When I speak to my patients in the clinic, I usually recommend to them that we start in what I call full court press, a basketball sports analogy, saying that I just want to start with the most efficacious therapy, offering them all the agents that have been shown effective, but that ultimately the best therapy is the therapy they can take. And there's no harm in dialing back as toxicity or side effects warrants in that patient. And so I think for us as clinicians, it's really important that we listen fully with empathy to the symptoms that our patients are experiencing. We may need to dose reduce the CDK4/6 inhibitors, which we know does not diminish the efficacy. We may need to consider discontinuing ovarian function suppression and going to tamoxifen alone, which at least for abemaciclib can be used together. And utilizing all the available supportive care regimens, whether that's doing exercise, adding medicines to control things like vasomotor instability or hot flashes, mood disorder, sexual health and intimacy support, to really maximize the quality of life that our patients are experiencing is really important. Dr. Robertson from Canada, in early stage hormone receptor positive breast cancer, what factors guide your decision to recommend extended endocrine therapy beyond 5 years? There is a really great tool from Dana-Farber, the STEP tool, that helps you predict the benefit that you can certainly utilize if you want something very data-driven that you can share with your patients. Often we're looking at factors like their anatomic stage of disease. Certainly I'm extending endocrine therapy in my patients with N2, N3 disease. Nodal positivity is one of the factors that really increases my probability of extending that therapy. I'm also considering clinical factors like their overall bone health. For a patient on an aromatase inhibitor who at 5 years is already developing signs and symptoms of osteoporosis, I'm more likely to be considering discontinuation of endocrine therapy based on the side effects that they're experiencing from that therapy. And then it's a little bit of shared decision making. If patients do have some toxicity from therapy but benefit from therapy, you have to kind of weigh those things. We do know that there's also available genomic tools that may benefit patients. I often am not utilizing those in my clinical practice because patients feel so strongly that one direction or the other is what's right for them. And based on their shared decision making alone, I already feel like we know which direction we're going to go. But for patients that, again, want a data-driven solution, you have those you can fall back on. Dr. Yamamoto from Japan says, could you share your perspective on how to better integrate survivorship care into oncology practice, especially for patients transitioning from active treatment to long-term follow-up? That's a great question. I think it depends a lot on your current practice and what tools and resources you have available and what your current workflow looks like. So a little bit difficult to answer on the fly. For those of us that have advanced practice providers or nurses that are heavily integrated into our clinical practice, one opportunity would be to have sort of a checklist or a toolkit that your staff could distribute to a patient either immediately before or immediately after the physician visit that just, says these are the resources that are available in survivorship, whether that's things like exercise therapy, physical therapy, sexual health and intimacy clinic, support groups, financial counseling, that helps make sure that they're getting all the tools that they need. You can also use, kind of a comprehensive review of systems as a part of your clinical visit that hits on the core elements of survivorship care, that you're monitoring for things like sexual health and intimacy, cardiomyopathy, peripheral neuropathy, weight gain, depression, all the different elements that are really beyond just risk of recurrence and adherence to medicines that we need to be thinking about as medical oncologists in the care and health of our patients. And think of that as sort of your new review of systems in the long-term follow-up of your patients. Those are really helpful, but I really think expanding the depth of your care team to include people beyond the physician is probably the most successful strategy to ensure that we're hitting all those elements for our patients. Dr. Nkosa from South Africa says, access to clinical trials remains limited in many regions. What steps can community oncologists take to help their patients benefit from research opportunities? Another fantastic question. I think that as we continue to expand the clinical trial landscape, what I would hope is that we are able to better incorporate clinical trials across low and middle income countries and more robustly across the globe. We have a long way to go. I think that we should start locally. We should be partnering with our regional collaborators. In Africa, for example, there's groups like Aortic and other councils that are working to bring clinical research opportunities into Africa. There's similar groups in Latin America, across other regions of the globe. Another key element is just things like cancer registries, because one of the core elements of understanding what research questions are critical to your patient community are understanding who the patients are. And often in low and middle income countries, one of the things that we don't have is even just the raw elements of who the cancer patients are that we're treating. ASCO, American Society of Clinical Oncology, last month launched in concert with Bloomberg the Global Health Financing Platform. I am not going to remember the proper name of it, but you can look for it online and sign up to be a part of that initiative. As a part of that, they are looking at some novel funding mechanisms to bring cancer research funding into low and middle income countries. I think it's a fantastic way for all of us to look to be involved in global research initiatives. Thank you everyone for submitting questions. It's so great to engage globally in dialogue about how to advance breast cancer care around the countries and around the globe.